bispecifics can be challenging because they carry with them sort of a unique subset of toxicities, typically require more consistent and attentive monitoring from the healthcare team.
That's Dr. Christine Barrett from West Virginia University Cancer Institute. We'll hear from her later in the show. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Today, immunotherapeutic potential of bispecific antibodies to treat hematologic cancers and solid tumors. We'll speak with two pharmacy clinical specialists on therapy, care coordination, and the unique challenges of delivering bispecific antibodies in the community setting. Our first guest is Dr. Aaron Cumpston, a pharmacy clinical specialist in hematologic malignancy and bone marrow transplant at the West Virginia University Cancer Institute in Morgantown, West Virginia.
So I think the bispecifics, or commonly called the BiTE therapies, have made a huge impact in the treatments right now of heme malignancies and starting to work into some of the solid tumor worlds. A lot of the treatments are very new and have happened just within the past year or two. A lot of FDA approvals have happened. And I think we're finding these drugs to be highly effective and having high response rates and also very durable response rates in very refractory patients. And so, these drugs are having a really big impact on the landscape of many disease states. And as we're finding more targets to hit with these bispecifics, we're able to advance this to more disease states. And I think we're also going to see these things move earlier in the lines of therapy as we start to use them more.
Are there any handouts or tracking tools that you're giving patients to use at home?
Yeah, so here at WVU, we are, as we're starting to do more higher volume of BiTE therapies, we've started creating some of our own handouts that we use for patients, but there's also handouts that are available on the websites of the manufacturers that kind of have a nice handout to give the patients about education of side effects and drug information on the medication.
What advice would you share to smaller or community or rural cancer programs that are just beginning to provide bispecific antibodies?
So I think my advice would be that just to, start preparing a plan for toxicity, for monitoring and toxicity management, thinking through the phases of care that we're going to be involved in with the patients. Some of the centers may refer the patients to start the therapy at a hospital that does higher volumes of CAR-T and BiTEs, and they may initiate those there, or some of the community centers are starting to initiate their own therapies there and do the early phases. And if they do that, then they just need to make sure they are thinking through their algorithms and how they're going to monitor the patients. Are they going to admit them? Are they going to do it outpatient? What is the education for the staff for 24/7 care to manage the side effects that can happen in the early phase? And then also I'd like to kind of talk through some of the toxicity management and things to think about, because I think that most of us, when we think about BiTEs, we are familiar with two main side effects that are the common things that we talk about. We talk about cytokine release syndrome, or CRS, and we talk about neurotoxicities. And those are the main things that most people are familiar with the BiTEs. And that is a very important part, especially in the early phases. That is when those things happen. And, in the early phases, they'll start to have these. The nice thing about BiTEs is these things do tend to be fairly modest in their severity and tend to be very controllable and treatable.
Do you have any final thoughts for your colleagues?
I think the other thing that many times doesn't get the attention that it needs is more the long-term management of these patients. So once you get through the initial phases and the patient has ramped up to the full doses and have got through the phase of cytokine release syndrome and neurotoxicities, and that's also a time where many of them will shift care to local centers to continue this for an extended duration of kind of longer term management. And that's a time frame where there's a lot more infectious complications. A lot of these bispecifics that we have right now in heme malignancy are going to target the hematopoietic cells, and depending on the different BiTE, but most of them will cause a significant immune deficiency down the road, and they'll need infection monitoring, infection prophylaxis, and then they'll also need some immunoglobulin monitoring. So their IgG levels are the antibodies that their natural B cells will produce. And most of these drugs in heme malignancy target those B cells, so then they don't have the antibodies they need. And so it's very common to monitor IgG. And if they are having recurrent infections, it becomes more and more common practice to give them IVIG supplementation, as well as monitoring them for infectious complications such as CMV or cytomegalovirus. If they are seropositive for CMV, it can reactivate and become an infection. So then we start incorporating some CMV monitoring into our BITE therapies. And these are things that many times will show up in the longer term management when the patients may be not necessarily at the center that may even start the therapy, and maybe somebody else may be picking up the continued therapy of it.
Next, we turn to Dr. Christine Barrett, an oncology clinical pharmacy specialist in solid tumor, also at West Virginia University Cancer Institute in Morgantown, West Virginia.
So they have really advanced the treatment landscape, in particular in solid tumors where I practice, specifically in the setting of uveal melanoma, where we had the first bispecific T-cell engaging agent approved for a solid tumor with tebentafusp. And so in these patients with uveal melanoma, in the absence of this new therapy, had pretty dismal prognosis with a lot of really poor treatment options that weren't very effective. And so tebentafusp has really offered a new opportunity for patients that provides adequate responses for those patients that qualify. So it's really exciting to have this in the solid tumor space as well now.
What challenges do you face when delivering bispecific antibodies to these patients?
So bispecifics can be challenging because they carry with them sort of a unique subset of toxicities, typically require more consistent and attentive monitoring from the healthcare team, and also have some unique ways to manage these toxicities as well. And so not even just in hematologic malignancies, but especially in solid tumors, this can be especially challenging because we don't have quite as much experience using these type of therapies yet, since it is very new for us to be using these agents for solid tumors. And so I think, ways to kind of overcome some of those challenges, of course, is to have protocols in place so that the healthcare team is comfortable with ways to manage and monitor these patients. And I think also for a solid tumor specialist in particular, really collaborating with our hematology colleagues, kind of gathering information as far as what has worked for them, ways that we can kind of improve our processes and implement something that works for our patients.
Can you share some of your best practices in care coordination for patients receiving BSA/BS therapies?
So again, I'll call to, our use of tebentafusp in our patients with uveal melanoma. And so this therapy, like other BITE therapies that are used in hematologic malignancies, carry a risk of cytokine release syndrome and, other infusion or therapy related toxicities. And so these patients require pretty significant monitoring, especially with the first few doses. And so really the best practices that we have found is implementing very detailed protocols and workflows for these patients so that it's very seamless from receiving their infusion to being typically admitted inpatient for observational monitoring with lab work and assessing all of those other vital signs that are critical for catching the early signs of cytokine release syndrome. And so those have been the things that have worked very well. Making sure that our staff is very well trained. Again, a lot of our nurses, our physicians, they're not as familiar with these BITE therapies in the solid tumor space. And so, again, just making sure that they're very comfortable with what to watch for.
What advice can you share with your colleagues who are listening from community practices?
Yeah, so I think implementing these BITE therapies can seem very overwhelming for institutions that maybe are not as familiar with how to manage these toxicities, all of the sort of logistical issues that they carry as well. And so I think my biggest advice is really to just reach out to other institutions, larger institutions that, have some more experience in handling these BITE therapies and see what kind of advice that they can offer. I know that in community practice, it can be really difficult, but there is a network of institutions out there that have, taken on administering these BITE therapies and have a lot of experience that can be very helpful for those in community practice.
Thank you, Drs. Cumpston and Barrett, for joining us today. You can check out the show notes for more resources on the uses of bispecific antibodies in hematologic cancers and solid tumors. This episode was made possible through support from Amgen. Until next time, for the entire Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.